Thank you for the introduction and also for the opportunity to present this evening. My name is George Sturgis. I'm a urology registrar from Pinderfields Hospital in Wakefield in the UK, and I'm joined by Alison Downey, who's a consultant urologist also at Pinderfields Hospital, specialising in functional urology and reconstructive urology. So thank you for also joining Miss Downey. We're going to discuss our paper, ketamine uropathy, and looking at our experience in managing these patients in a UK hospital. I think this is a really interesting and different audience for us to present to as urologists. I can see that a lot of the previously discussed papers have been looking at the sort of positive therapeutic aspects of ketamine use in a supervised environment for patients with mental health issues. However, who we manage what we manage is the increasingly alarming number of patients with significant urinary tract problems relating to recreational ketamine abuse. And part of the background to this study is we know that we have a very high number of patients in the areas that we look after as urologists. Moving on to a bit of background, I'm sure most people listening are far more knowledge about the pharmacology and clinical use of ketamine. So I'll just give a bit of background about ketamine uropathy itself, also known as ketamine bladder or ketamine cystitis. This condition occurs when there is significant damage to the urothelium, which is the lining of the urinary tract due to long-standing recreational ketamine abuse. Patients present with typical symptoms of urinary urgency, frequency, and small bladder capacity, often needing to go to the bathroom every 30 minutes or more. This is usually accompanied by a significant amount of pelvic pain, which can also be difficult to manage. As the condition progresses, patients can get upper tract involvement, and that presents itself as ureteric strictures, hydrone phrosis, and ultimately obstructive renal failure. The exact mechanism by which this occurs is not completely understood, but all the evidence points toward it being a direct toxic effect on the urothelium from the metabolites of ketamine that are excreted in the urine rather than their systemic effect. There's previously been a significant geographical variation in the incidence of ketamine uropathy, as the incidence is related to recreational drug habits for any given population. Much of the early work has come from Eastern Asia, and case reports first started to appear about ketamine uropathy in 2007. Much of the early work's been done in areas such as Hong Kong, Singapore, and Taiwan because they have very high ketamine usage there. And prior to this, data from outside these areas was fairly sparse. Looking at ketamine in the UK, annual usage in young people is going up. 3.2% of 16 to 24-year-olds used ketamine at least once a year in 2020, and this was the highest figure to date. Data about ketamine uropathy in the UK is fairly limited, and there's no formal treatment guidance from any of the national bodies or medical societies. What we do know is that it's increasingly forming a large part of both our emergency workload and our clinics, and this is an experience that's mirrored by urologists throughout the region. So back to our study. This was a retrospective cohort study aiming to identify all patients with ketamine uropathy that presented to our unit and our network over a 10-year period. This ran from 2011 till 2021. There's no particular ICD-10 code for ketamine uropathy, so we had to search for these patients through theatre lists, clinic lists, and emergency presentations. Inclusion criteria were patients who had typical low urinary tract symptoms in keeping with ketamine uropathy in the presence of a long-standing history of recreational ketamine abuse that's been diagnosed by a urologist. Our aims were fairly broad-reaching. We wanted to know how many patients we'd seen, what we did for them, and ultimately what happened to them. So this is our cohort over the 10 years of study. We found 81 patients with a diagnosis of ketamine uropathy. 71 of these came from one particular hospital or town called Barnsley. It's a fairly small area, has a population of about 250,000. It's a fairly poor area, but apart from that, we're not quite sure why it has such a high incidence. 72% of patients were male. Average age of presentation was 26 years and average length of follow-up was 34 months. However, some patients were followed up for as long as 10 years. That being said, about a quarter of patients were lost to follow-up at the end of the study period. And for those patients that were followed up for a longer period of time, they would frequently come and go and be temporarily lost to follow-up. So follow-up was not completely continuous. There was a high incidence of mental health diagnosis in these patients at 30%. And daily use of ketamine varied between 1.75 grams a day and 7 grams a day in the more severe cases, although this wasn't documented particularly well throughout the study. Some of the baseline biochemical data is displayed in the table, and around a quarter of patients had hydrone phrosis, which is quite a large proportion. So this figure shows the incidence of new diagnosis of ketamine uropathy throughout the duration of the study period. And you can see that from around 2017 onwards, there was quite a large increase. We stopped collecting data for this study in early 2022. And unfortunately, what we've seen is this incidence has continued to rise both this year and last year. And now we're seeing more and more of these patients. So looking at the upper tract disease in a bit more detail, upper tract involvement initially presents itself through hydronephrosis, or swelling of the kidneys. And the rows that you can see in bold in this table, which is a univariate analysis looking at patients with and without hydronephrosis, both total follow-up time and serum GGT were significantly higher in the hydronephrosis group. In our study, we feel that total follow-up time is a good marker for total duration of use. And what this shows is that the longer patients are using ketamine for, the more likely they are to develop significant upper tract disease. Serum GGT forms part of the liver function tests, and previous studies have highlighted that a raised serum GGT is associated with the development of hydronephrosis and upper tract disease. And that's something that was mirrored in our study. It's also our opinion that GGT is raised when patients are actively using ketamine, and so this could be a useful marker for this. Another reason why it's important to monitor patients' liver function tests with long-standing recreational ketamine abuse is to screen for the development of ketamine cholangiopathy, which is another possible complication. And this is associated with significant liver enzyme impairment. They get structural changes with non-obstructive biliary ductal dilatation. And in severe cases, this can progress to hepatic failure. Renal function was significantly worse in the hydronephrosis group, as is expected. So this is a CT urogram, which shows the typical appearances of a patient with ketamine uropathy. So a CT urogram, there's a delayed phase and there's contrast in the urinary system. So what you can see here is there's a significantly dilated renal pelvis on both sides. And tracking down, you can see the ureters on both sides. These are significantly dilated. They're almost the same width as the patient's aorta, which shouldn't occur. And this goes down into a very small, thick-walled, contracted bladder with a small capacity. And these are the typical appearances of ketamine uropathy that has bilateral ureteric reflux due to this very contracted, thick-walled bladder. This is a nephrostogram, another complication patients develop in their upper tract of ureteric strictures. And what this shows is this patient has a nephrostomy in situ, which is what you can see coming into picture here. And contrast has been injected down the nephrostomy. And what you should see is contrast passing down the ureter, which in this case, again, is significantly dilated. And it should then pass into the bladder down here. This doesn't happen in this case because this patient has a complete ureteric stricture close to where the ureter enters the bladder. So this patient is nephrostomy dependent for drainage of this kidney, which is one of the more concerning complications of ketamine uropathy in these stricture formation. Looking at our management of upper tract problems in a bit more detail, there were 6 patients that needed nephrostomy insertion throughout the study period, 4 of which were bilateral. For anyone who's not particularly familiar with a nephrostomy, it's a percutaneous tube that's inserted into the renal pelvis, and this allows urine to drain into either a catheter bag or a stoma bag. This bypasses any blockage such as a ureteric stricture. They're not perfect devices, that they need to be changed every 3 months. They can leak and they can bypass, and they often lead to a high number of presentations to the emergency department. We've had 2 patients with bilateral nephrostomies in place for over 2 years, as often to make them nephrostomy free, they need to undergo major reconstructive surgery. When they're still actively taking ketamine, the complications for this in previous studies have been shown to be very high. So this is often a barrier to this. But I think it's important just to note that, particularly given the young demographic of this patient cohort, having bilateral nephrostomies for an extended period of time can have quite a significant psychological impact. Looking at the management in general for these patients, by far and away the most important thing that we can do for them is to encourage abstinence, and that needs the involvement of local drug and addiction services. The availability of these services is massively variable even within the UK, and I'm sure is more so globally. What we know is that despite our best efforts with medical therapy, if patients are still actively using ketamine, their symptoms won't get better, and they'll almost certainly get worse. With abstinence for long periods of time, some patients report that their symptoms get back to a level close to their baseline that are tolerable. However, a proportion unfortunately don't, and they're left with significant symptoms that are lead to a significant reduction in the quality of their life. In terms of improving their symptoms, there's a range of medical options that we can use. Anticholinergic or beta-3 agonists are often prescribed in overactive bladder, and they aim to deal with the symptoms of urinary frequency and urgency and the small bladder capacity. 75% of patients were on at least monotherapy, and 38% of them were on dual therapy. And the typically used agents for us were solifenacin and mirabegron. For patients who'd been abstinent for longer periods of time, we were able to offer intravesical treatments, so treatments within the bladder. And one of the more commonly used options was a gag layer replacement, which aims to replace a sort of a protective layer of cells in the bladder with a brand name of Cystistat. So 11 patients underwent this procedure, and 3 patients underwent intravesical Botox therapy, which is fairly well established for overactive bladder outside of ketamine uropathy. But more work needs to be done to see its effectiveness in these patients. In terms of surgical management, quite a high proportion of our patients underwent cystodistension. Cystodistension is a surgical procedure where the bladder is stretched with fluid in an attempt to increase its functional capacity. And nearly 3/4 of our patients underwent this procedure at some stage. Average bladder capacity, once stretched, was found to be 260 mils, which is very low. What we found after this procedure is patients had quite a varied response. Some reported good temporary benefit, however, some reported not much benefit at all. The procedure itself can be quite challenging because the typical ketamine bladder is very fibrotic, has a very small capacity, and is very prone to significant bleeding during the procedure. Because of these reasons, and mostly the varied response, this is more of a historical practice now due to the length of the duration of our study, and we're not offering this treatment as much as we used to. Looking at the more invasive reconstructive surgical options, only 1 patient underwent reconstructive surgery in our cohort, and that was a subtotal cystectomy and a substitution cystoplasty for refractory symptoms in someone who there's someone about to speak. What the literature shows is that patients who are both actively using ketamine and relapse after reconstructive surgery are at very high risk of complications. So we don't routinely offer any form of reconstructive surgery for patients unless they've been proved to be abstinent for a long period of time. These are examples of some of the surgical treatments that are available. So an enterocystoplasty, similar to a substitution cystoplasty, aims to increase the functional capacity of the bladder by using part of the bowel, usually the small bowel, So the bladder is opened, and the small bowel is used to increase the capacity of the bladder. One of sort of the unknown entities in complications relating to ketamine uropathy is the bowel maintains a absorptive capacity, and particularly in patients who may have this surgical procedure and then go on to relapse. What's an unknown is what effects on the gastrointestinal and systemic system there may be due to reabsorption of these ketamine metabolites. More of an invasive procedure is cystectomy and ileal conduit formation, and that's where the whole of the bladder is removed. The two remaining ureters are plumbed into a piece of small bowel, which is brought out as a stoma or a urostomy. And this means patients are required to have a urostomy permanently, draining to a bag of urine. Ureteric strictures can be surgically repaired. The particular technique depends on where they are anatomically. Generally, more proximal strictures closer to the kidney are more difficult to repair than more distal ones. And in severe cases, there is a case report of a patient in the UK who underwent renal autotransplantation due to recurrent problems. They'd had a previous reconstructive surgery. They relapsed and they basically ran out of viable urothelium, so had to undergo renal autotransplantation. But that just highlights the issue with patients who have surgery and then relapse, which is why we're so keen for patients to be abstinent for long periods of time. So for this major surgery, patient selection is really key. Looking at the histology we had available from our patients, we had histology available from 18 patients in total, 17 who were biopsied at cystoscopy when they were undergoing cystodystension, and the one patient who underwent subtotal cystectomy. What we found is that each case just showed the typical features of ketamine cystitis, and there was no evidence of malignancy. Typical findings are urothelial denudation, chronic inflammation, and replacement of the lamina propria, which is a layer of the bladder with a fibrous tissue. The lack of malignancy is important because in the literature there's reports of bladder cancer in patients at a very young age with concurrent ketamine use. However, the histology was fairly atypical. They were sarcomas and yolk sac tumours. One of the typical presenting symptoms of patients with ketamine bladder is visible hematuria, and that's also a sign of bladder cancer. So we do still investigate patients that have persistent heavy visible hematuria, but it is reassuring that we didn't find any evidence of malignancy in our own cohort. Mortality rate over our study period was 2.5%. We had a 35-year-old patient who developed progressive ketamine cholangiopathy after a long-standing history of ketamine abuse, and ultimately this led to fulminant hepatic failure, and he passed away despite intensive care treatment. Another patient was a slightly younger male with an 8-year history of ketamine abuse who was still actively using, who developed bilateral pyelonephritis and renal abscesses in obstructed hydronephrotic kidneys, who unfortunately died of sepsis. I think when you look at the age of our patient demographic, I think 2 patients is fairly significant. Some of the limitations of our study, and the main one is its retrospective nature. So it's over a 10-year duration, and our practice has changed over that 10-year period as we've learned more about ketamine uropathy and what we think works and what we think doesn't work. Another limitation is the lack of a validated patient symptom score for their urinary tract symptoms, which would enable us to objectively categorize them and to sort of score them. But again, because of the retrospective nature, this wasn't possible. The final main point is that abstinence or patient-reported abstinence and what comes back on the drug screening don't always agree. And although we are far more frequently testing patients' urine for ketamine, we weren't historically. So it can be difficult to match these up. And I think what that does highlight is the fact that a lot of these patients are often in a difficult position where they're using ketamine to deal with the significant pelvic pain that the condition causes. And this can lead to a vicious cycle where they're desperate to seek some sort of intervention from us. Moving on from our study briefly, I just thought we'd share how we assess patients presenting with ketamine neuropathy when they're new patients. So we feel that all patients should have their renal function and their liver test screened to screen for any obstructive uropathy and also the development of cholangiopathy, but it's also a screening tool for upper tract disease and active use. Ideally, they should have some sort of objective screening tools. The PUF questionnaire is just a symptom-based score of their lower urinary tract symptoms. Ketamine-specific information is really important, so both the duration of abuse and the dosage that they're using. The measurement of their functional bladder capacity, which can be done through a measurement of void and a post-voidal bladder scan. And then all patients should have their upper tracts assessed for the presence of hydrone phrosis. If it is present, they should undergo further imaging, but this is obviously something that we're doing as urologists. Moving on to a management pathway for these patients. Again, abstinence is absolutely key. Anything else that we offer them will ultimately be futile if they continue to use ketamine. But it's not always easy to do in practice. So this needs the involvement of local drug and addiction services, counselling, and anything else that we can offer to help. Symptom control in terms of anticholinergics and mirabegron are used frequently, and we refer a lot of our patients to a chronic pain service. We feel this is best done by a specialist team because these are a patient group who are at high risk of addiction anyway. So particularly prescribing controlled drugs needs to be done in a safe environment. Upper tract obstruction, so obstructive uropathy at any stage of their presentation needs to be managed, and that's almost always with nephrostomy insertion. And then, as we discussed, patients who've been absent for longer periods of time can go on to have intravesical therapy with cystostatic or Botox. And then for the very small number of patients who've been absent for longer periods of time but still have real troubling refractory symptoms, reconstructive surgery is an option, but patient selection is difficult in these procedures. So in summary, ketamine neuropathy causes severe urological symptoms. In the UK, we know the incidence is rising, as is the use of recreational ketamine, and this is quite concerning for the future as urologists. Abstinence is absolutely key, and unfortunately, adherence to follow-up is poor for various reasons. Currently in the UK, formal management guidelines are lacking, but that is something that might be changing in the future. That's me finished. Thank you for listening. Does anyone have any questions they'd like to put to either myself or Miss Downey?
That's brilliant. Thank you very much indeed, George. So let's just have a look at the chat and we'll go through those questions first, as I said. So the first question is about how people are using their ketamine. Are they snorting it, or is it oral, or can you say anything about the predominant route of administration?
Yeah, so the vast majority are taking this nasally or snorting it. I've heard sort of anecdotally people occasionally injecting it or smoking it, but the vast majority are taking this nasally.
And presumably, given the mechanism of action with this sort of direct urothelial use, then it doesn't matter particularly which route it's taken by in terms of the risk of developing uropathy. Well, I mean, I guess the numbers might be
not as far as we're aware. I mean, it's very unusual that you hear anyone taking it in any other way apart from nasally. So I think any evidence that or any opinion is very much anecdotal. But yeah, it's only a couple of cases I've ever heard of people taking it recreationally, intravenously. So yeah, it's the vast majority are taking it nasally.
If I could, there is some evidence that if you take it nasally that you've got worse ketamine neuropathy, but I suspect that that's a dose-related thing because it's much easier to snort significant quantities. So there's a little bit of evidence that snorting has a higher incidence of problems versus injecting, but it's very limited evidence, as all of this is.
Vislav says, thrilling data. Please let me know whether there are any alternatives to cystoscopy for urocystitis safety oversight.
No. Unfortunately not. What we absolutely don't do is do flexible cystoscopies under local because of the incredible pain that they get. So we would do this under general anaesthetic. And you have to be very careful with it. We have had a number of perforations actually from very gentle cystoscopy, and we've had a patient who ended up in intensive care with a perforated bladder extraperitoneally, so it was a conservatively managed bladder. So we're really, really careful with them. I don't think you need to surveil them. The case reports of cancer are extremely low. And I think that once you've had one look in and taken a biopsy to confirm it absolutely isn't cancer, then we wouldn't generally cystoscopy them very regularly unless something changed. But there's no alternative, unfortunately. No scan will show you urothelium like a scope.
So if I can ask a follow-up question to that, so am I to understand that you wouldn't use a scan really for the purposes of making a biopsy to diagnose the cystitis? You're doing it to exclude cancer?
Yeah, you're looking for upper tract problems. You're looking for hydrone, phrosis or strictures or any obvious cancers, but you wouldn't do it to look at the urothelium itself.
Okay, well, we'll come back to that because that's very interesting. Thank you. Okay. Ryan McNamara says, what's the experience of clinicians who are prescribing oral ketamine to lengthen the positive effect of an initial course of intravenous ketamine? Do clients ever develop bladder / upper urinary tract complications of the regularly prescribed oral ketamine? I'm happy for anybody else to chip in and answer this. I can say something about it, but George and Alison, have you got anything that you want to say about that?
I think it's still not gone. There you go, Mr.
I would say that if you look at the literature, there's actually very little evidence that medically prescribed ketamine causes ketamine uropathy. The case reports that I've seen have all been kind of historical from the 1980s in pediatric patients who were having quite high doses of ketamine for chronic pain. And locally, anecdotally, I was speaking to one of our anaesthetists recently. They had one case of medically induced ketamine uropathy in a 15-year-old girl who was having quite a lot of ketamine for changes of burns dressings. We've got a pediatric burns centre, but actually the evidence of medically induced ketamine uropathy seems to be very low, which is very reassuring, and I suspect that's dose dependent. That would be my limited knowledge of it.
Okay, that's very helpful. And in fact, what I'm going to do is I had an email from somebody who can't come to this meeting, but has treated an enormous number of people with medical ketamine. And he asked me to say the following. There's a growing fear among patients receiving ketamine in a clinical setting that ketamine cystitis is a real potential complication. After 50 years of administering ketamine for medical and psychiatric indications, I have never seen a case, and case reports are nowhere in the anaesthetic literature after 60 years of use, even in burn centres where large doses are administered IV daily for weeks for changing dressings and wound debridements. It's important that our patients are not stressed with unnecessary fears of developing this malady and need to be reassured that it is only seen in patients with long nasal abuse histories. So that's very much concordant with what you're saying. Thank you. That doesn't quite answer the thing about oral ketamine. I can say something about that because we have been using a strategy along the lines that Ryan mentions. So we give intravenous ketamine perhaps once every 4 weeks, and then oral ketamine once a week on the intervening weeks, taken at home. The typical maximum dose of oral ketamine is 300 milligrams. But more usually it's in the range of, it's more usually about 200. We've done a prospective series getting people to give us their bladder symptoms, and the bottom line is that we don't find any particular problems, even with the people who've been on it for 10 years or higher doses. There are sort of idiosyncratic cases where patients seem to have an increase in their bladder symptomatology, but in general, the ketamine relationship between ketamine use and bladder scores is that their scores go down the more ketamine they use. And the reason for that is because it's related to the improvement in depression. That's just anecdotal. I mean, it's not anecdotal at this point. There's about 250 cases in that series, but we haven't published that yet. Next question. Thank you, Alison, for this informative feedback. Per FDA and EMA guidance, it is obligatory to use cystoscopy in the long-term studies with ketamine and its enantiomers when the urocystitis is observed in preclinical models. It is a key limiting factor for such trials, as the expected trial participation is at least 12 months for maintenance effect demonstration. Yeah. So let's just go through that again. Wisław, it might be useful for you to come on and talk about this, because are you really saying that the FDA is mandating that everybody has to have a cystoscopy for having a 12-month maintenance trial?
Yeah, so thank you for this really vital presentation today. And I think in line with Roger McIntyre's team, you provided very good feedback on just the issues to be concerned when we think about the risks for ketamine use regarding uropathy. And to me, when I follow the pipeline in a number of pharma entities who push forward ketamine formulation for mood disorders, the regulatory seems to be very much urging that, in the majority of cases, that they want to have in the maintenance phase studies, cystoscopy every 3 months to demonstrate the safety, which is, it is the key limiting factor. You cannot actually, be reasonable trying to start a trial, because people will simply, quit the trial for cystoscopy. On the other hand, there is a lot of data from such kind of observational registries like you provide, and lessons learned from the nasal spray as ketamine, with no issues actually within this area. While on the other hand, especially when we do preclinical studies and phase 1 studies, sometimes it happens just by the number of statistics that you observe some kind of challenges related to uropathy. So I was just wondering, because to my best knowledge, and thank you, Alison, just for clarifying this, there is no alternative. So if you want to have a good oversight, it is a must be to have a cystoscopy. But I was just wondering how to bring up to discussion between the academia industry and the researchers and regulatory to come up with some kind of the pragmatic oversight for the safety. Because to me, it's just my personal opinion, it's the matter of the dose exposure in time, and it is the dose range and the exposure in time this several times higher that we use in psychiatry. And it's this is what actually Rupert mentioned from his colleagues, just you even when you do the wound dressing and in the long term, you still do not see this as the factor that's truly contributing to the safety oversight. So I'm just trying to have my own mind when such a kind of discussions appeared, whether there is any kind of room for some kind of pragmatic approach with patients' benefit in mind to bring those especially long-term data demonstration from general perspective of data set.
I'm not sure, although what I would say is we don't look at their bladders. We don't do a flexi unless they've got hematuria, because the symptoms and the timeline and the ultrasound usually actually tell you the whole story. So I wouldn't routinely flexi all of them. If they don't have hematuria, I wouldn't look in. So I don't know if that's helpful to you, but that would be our sort of view. And 3 monthly flexible cystoscopies is quite a thing to put people through, actually.
I fully agree, and I would just follow, being closely, watchful on hematuria, and it seems reasonable.
Would you limit cystoscopy to those with frank hematuria, or what happens if they have just a trace? Is that helpful in diagnosing cystitis?
There's just the frank hematuria, to be honest, because what I really want to make sure is that they actually do have ketamine uropathy and it isn't a bladder cancer. Although I've never found one yet, there's always that fear. As a urologist, it's very hard to ignore visible hematuria, whereas non-visible hematuria wouldn't. In a young patient of this age with ketamine use, I wouldn't rush to scope them unless there was something very strange going on. Yeah, visible hematuria would be my only indication to scope them.
Well,
can I put it in a slightly
for,
different way, if I might ask a sort of related question? If you've got somebody who's had quite a lot of medical ketamine at low dose, and they develop cystitis, or they develop some symptoms of cystitis, is there a way that you could help us to think about what the investigative strategy for those patients should be, and at what point you'd be actually thinking, we need to look and find some definitive way of establishing whether this is ketamine cystitis or not?
Yeah, it's going to be difficult. I do have one patient who is under the chronic pain team and has been using ketamine for many years, who also has quite a lot of lower urinary tract symptoms, but she has an awful lot of other reasons to have urinary tract symptoms. So it's really hard to pick that apart. I think the thing that I would suspect, there's no evidence for this, but my own thought based on what I see, is that if the lower urinary tract symptoms were of chronic ketamine use, I would expect to see hydronephrosis on an ultrasound scan, and I'd also expect to see the liver function tests going off, because that would, you get a lot of hydronephrosis because of reflux and poorly compliant bladders in this cohort, and that seems to be a chronic use sort of pattern, rather than you've just hammered it into you for one weekend once. So I think that would probably be the way to do it. I think the only way you could absolutely tell would be to stop using the ketamine, because the vast majority of patients 6 months later, their bladder symptoms will either resolve completely or improve significantly, and that would then tell you that it is a ketamine problem, rather than just having got lower urinary tract symptoms because you have lower urinary tract symptoms. But unfortunately, there's no test that you can do to pick that apart. Unfortunately, it's a really difficult area. So that patient I've mentioned, she is coming off ketamine to see if her symptoms get better, to see if it is due to ketamine. But it's really difficult. I don't think there's an easy answer.
Well, that's incredibly helpful, because it's a very practical thing.
Yeah.
It's a very practical recommendation. So thank you for that.
Actually, Rupert, if I might just comment, it is an eye-opening, hypothesis-provoking. So it seems that my mind was just over-confused with thinking, while re-challenge paradigm is far more helpful. Thank you. You made my mindset. Thank you.
Mike Harris asks, is there any evidence that S-ketamine can produce renal problems?
Not to my knowledge, I'm not actually too familiar with S-ketamine. It is definitely ketamine and norketamine, certainly, and it seems to be the metabolites of them. So if S-ketamine is still metabolized by the kidney and excreted in the urinary tract, then it probably is involved in it. I suspect the people that we see aren't using S-ketamine, they're using whatever they can get their hands on. So I don't really know, and I think from a urology point of view, we're dealing with the sort of recreational use rather than things like S-ketamine and that sort of way.
Yeah, that's helpful, thanks. And in chronic users, how long does it typically take for the symptoms of ketamine-induced urinary issues to manifest? How long do you think it's going to take for that?
That's a really difficult one, because a lot of our users don't necessarily tell you exactly the whole story when they started, how much they're taking. So in the literature, it's anything from 2 weeks to 6 months of taking. But I suspect it's going to be dose related, possibly related to snorting or injecting, and then chronicity of use as well.
And Marco asks, could you speak more as to why it might be that your cases were so clustered in one area? Do we know any particular populations or drug impurities increase the risk or make it more likely patients will present? So are there any other cofactors?
Yeah, it's really interesting actually. So out of this, we are going to have UK guidelines because I've escalated this to our national body and I've written some. And when we spoke at our national meeting, there do seem to be little pockets around the country, and they're not where you would expect them to be. So we know that students use a lot of ketamine, but if you go to our nearest largest city, which would be Leeds or Sheffield, they have single figures of these patients. They don't see that many of them. Whereas if you go to Barnsley in particular, it's a very deprived area. It's quite a low socioeconomic status. There's quite a high unemployment rate. There's no university, so it's really hard to know why these patients are taking it there as opposed to in Sheffield or Leeds. If you go to London, they've got half the number of cases over 10 years that we had, which is incredibly interesting. But if you go to Norfolk and Norwich, which is not that far from London, they have a similar problem that we have, but they've got a completely different kind of demographic of patients. So I really don't understand why certain areas seem to have a high prevalence of use. I can't pick out anything in particular. I'm not sure that it's anything to do with the impurities in the drug, because there's been a lot of animal models with mice using pure ketamine that have had the same outcome. So I suspect it's not the drug, it's actually just why are they taking that particular drug in that particular area. It's very strange. I don't understand it at all. And none of us do, actually. It's really interesting.
Do any of your patients say that they were treating themselves for depression?
That's a really interesting one. So we don't have that many that have done that. I've got 2 patients who have self-diagnosed ADHD and have started taking ketamine to treat themselves. But my colleagues down in Norfolk have a high prevalence of patients with depression and ADHD, autism, who have been self-treating with ketamine as well. And that's my slight concern about its therapeutic uses. If you've got a patient who gets a really good response from ketamine, because I know there's good evidence for its use in mental health problems actually, but if they happen to live in an area where you can go down to the bus stop and get a whole load more ketamine, I'm slightly concerned that those patients might then top up their own doses. But that's sort of just a fair sort of thing from our point of view. But yes, Norfolk, definitely there are people self-treating for depression and ADHD, and certainly we've got 2 that I know of that are self-treating for ADHD, and that's really difficult to unpick because it is actually helping with their mental health problems. But obviously now they've got problems that are going to cause mental health problems, so it's a bit of a vicious circle for those patients. So just be very careful with patients that are being treated medically with ketamine to be clear that they need to stick with the doses that are being prescribed by you guys, which are safe, and not try and top it up. I think that would be the main thing to get across.
Yeah. The folk from the Global Drug Survey did a lovely presentation at a conference that we were at a few years ago, showing, and this was big survey, international survey of drug use, and they asked questions about self-treatment with ketamine. And what was clear is that people who treated themselves with ketamine were likely to take higher doses, to take them more frequently, and to be and to wish that they were taking less than people who were taking it recreationally. So, you know, there's some evidence that if you start recreationally and you think that it's treating you start self-treatment with that there is a bit of a gateway effect and an increased dose. But I think that most people's experience will be, you know, when you're running a ketamine clinic, the gateway effect really doesn't exist. People at least not at the moment. But of course, if you had a very, very readily available, easily accessible form, then that could be a very different scenario. So, and David Rosen says, in my clinic, I have several chronic pain patients who are maintained on 400 milligrams of ketamine daily. Does this regime make you uneasy?
Well, if they don't have any bladder symptoms, then no. I think the majority of our patients, you know, they buy it in grams, so they're taking already in the one dose, they're taking 2x, 3x what is medically prescribed. So my answer is probably not, actually, based on the evidence that I can see. And as long as, you know, the patient is fully counselled, and they've obviously got sensible people who are going to highlight if you get hematuria or you develop lower urinary tract symptoms, tell us and are aware of this, then that doesn't make me too uneasy, as long as they don't have symptoms. But we've got patients who take, you know, 4 or 5 grams every other day, which is very worrying. So 400 milligrams seems like a very small amount compared to those.
Right, thanks. Other questions? I have a few more questions, if I may, but let's please do keep them coming. Everybody else, you referred to the PUF questionnaire, and I think I mentioned just before we started about the interstitial cystitis problems and symptoms index, the ICPSI. You referred to the fact that there's no validated questionnaires. Do you have any comments about, you know, the assessment of these sorts of symptoms that might be relevant to cystitis and how we should best do it?
Yeah, I mean, the one you're referring to is validated, but it's validated specifically for interstitial cystitis or bladder pain. It's a very good questionnaire. The PUF questionnaire is a much more simple one. And the reason that we would like to do that one is because of the nature of the people that we are seeing with ketamine uropathy. To be honest, we're doing very well if they turn up to clinic. We've got quite a high DNA rate. We've got a high rate of people not being compliant with things we ask them to do. So I very rarely am able to get anyone to fill out a validated questionnaire. If they turn up to clinic, it's a bonus. So it'd be nice to have it, but it's very difficult to get it with the nature of the patients that we've got. And I think it'd be difficult to make a validated ketamine questionnaire for that reason, because you can't get a good idea of what they're actually taking, when they're taking it, how long they've taken it for, what their symptoms are actually like, and if they're telling you the whole truth of the matter, if that makes sense. So I think it's a tricky one. We chose PUF because it's easy.
I'm going to try and put you on the spot as if we haven't done that enough already, but to ask you a really tricky one, and that is, you know, if you were us and you were treating people with ketamine and on a regular basis, say, you know, possibly every week or every other week, which is what happens with the S-ketamine patients, and you were trying to, you know, you thought there was a balance to be struck between reassuring people and doing something pragmatic. From a urological perspective, what would be the frequency that you think you'd need to complete a questionnaire, as some sort of questionnaire to keep an eye on symptoms? Or do you think that actually it's just better to react if they complain of something?
Yeah, I think there's no real normal about how often you pass urine. So it's all sort of subjective. So I would suggest that the patient would know if the patient tells you that they're passing urine more frequently, then that would be a reason to do it. And what would probably be useful is asking them to fill out a bladder diary prior to commencing treatment, so that if they did think that they've got an increased frequency, you could just simply get them to do a repeat bladder diary, and you'd be able to see very quickly whether it had actually increased significantly, or whether actually they might just be a little bit concerned about it and thought that it had gotten worse. So a bladder diary is a really simple way to do that. And I think if you could use the interstitial cystitis one, but again, you'd need a baseline to go off so you could see whether there was a change and then take it from there. But I think patients are pretty on the spot with their bladder symptoms, because if you're getting up more at night time to pass urine, you'll have less sleep. You're more likely to tell someone about that. With our patients with ketamine use, they can pass urine every 15 to 20 minutes. So if you were getting someone like that, I'd be really concerned. Somebody that's paying once or twice more, I'd maybe keep an eye on. But if they started to get a lot of urgency or visible hematuria, then I would start to consider problems.
Okay. Marco asks, for high dose clinical uses, e.g. burns, does anyone co-prescribe drugs for urine damage prevention, for example, anti-inflammatories, if the cause is in part inflammation mediated, or is the mechanism too unclear for this at the moment and the risk too low clinically?
Yeah, there's nothing you can do to protect the urothelium. The cause of it's really difficult to pin down. There's absolutely a problem with the barrier in the bladder. First of all, there's evidence that you've got the breakdown in the gag layer that lines the bladder. There's also a lot of neurogenic inflammation, so it's not just sort of your normal kind of COX-mediated inflammation. It's neurogenic, so they tend to grow more pain nerves, in a really simple term, in their bladder as well. And there's a lot of microvascular damage as well, which we think is why you get quite a lot of complications with reconstructive surgery, because obviously you're doing a lot of anastomosis. So I think there's nothing you can give to protect the bladder. I think the main thing is just to be on the ball with, if you see that they're starting to get symptoms, decreasing the dose or stopping using it, because a dose of that amount of time in burns, for instance, that's not going to be a long-term thing. So you can very quickly get their bladder back to normal. There definitely is a reversible aspect to it, and the quicker you get them off it, their bladder will probably go back to normal.
Can I ask about the blood tests? So I was interested in what you said about the gamma GT and what was the other one?
Right.
Do you think that and I know this is sort of slightly off topic, but the issue about the idiosyncratic liver damage, the cholangiopathy, can you say anything about how likely it is that somebody who has got interstitial cystitis is that their gamma GT is going to be raised?
Yeah, or to discriminate between the two of them?
No, just yes, let's have that. But also, is there any sense in which gamma GT is useful as a sort of marker of interstitial cystitis? You know, if you were trying to look at whether somebody's urinary symptoms were related to the ketamine or were just incidental, would the gamma GT help you?
Yeah, absolutely. So interstitial cystitis does not cause raised gamma GT.
Okay.
In ketamine is because of the cholangiopathy. So because there's a small amount of it is metabolized by the liver, you get the same problem in the common bile duct as you do in the ureters. So they quite often will have dilated common bile ducts on MRCP. To my knowledge, the hepatologists can't do anything about that. But that's why they get the gamma GT. So I'm very suspicious of young patients with hematuria, lower urinary tract symptoms, who claim not to use ketamine but have a raised gamma GT. I would presume they're using ketamine until they can prove otherwise. But it isn't raised in any other bladder dysfunction.
And do you think that the gamma GT and the cholangiopathy occur before the cystitis in some patients then?
No, I think the cystitis comes first. It's very difficult to tell, but my gut feeling is you get the cystitis symptoms first. You definitely get the reflux from your poorly compliant bladder. I think then you get the uroteric strictures. And when it's got the uroteric strictures, that's when you start to see the cholangiopathy come in. So it's usually prolonged use, definitely associated with hydrone or phrosis. So I think it's a timeline of disease that you get that in. So I think the cystitis comes first.
That's really helpful. Thank you. Steve Hamilton asks, your thoughts on the utility and sensitivity of O'Leary-Sant voiding pain indices questionnaire for baseline and periodic follow-up?
Yeah, like I said, there's no validated questionnaire specific to ketamine, but those are really good questionnaires, and therefore bladder pain syndrome or interstitial cystitis. So I think they'll give you a good baseline and they'll give you something to go along. So I think they're probably the best in-depth one. And probably for the cohort of patients you've got, they're probably easiest to use and give you the most information. So I think they're very good.
I mean, they're better than the ICPSI.
I think the O'Leary-Sant is the same one. They've got two different.
Oh, is
yeah,
it? Yeah.
O'Leary are the two people who designed those.
All right. Okay. Thanks. Yeah. Okay. We've kept you at it. Thank you very much. I mean, have we got any last questions? We're starting to run out of time. People want to get home to their dinner in the UK. Look, that was really terrific, really great, practical, clear, great data, great, sort of useful clinical opinions. Can't say more than that. Terrific. Thank you so much. Really, really wish you well with the next phase of this. And George, congratulations on getting such terrific data together.
Really thank you for having us.
Thank you, Alison, as well, for helping us through with all those the nuances of all that. It's a terrific discussion.
No problem. Thanks very much for inviting us. It's always nice to speak across different specialties, I think.
Isn't it? Yeah. Thank you very much. Okay. Cheers.
Bye.
Bye-bye. Yeah.